So we've asked the question, have we got this definition right? Is it a marketing ploy or is it a real condition? Is it there to clarify how we talk to our patients? Does it help the scientific body to move ahead with what may be a real condition or maybe a bunch of conditions? And does it stop us thinking? Well, Norman wouldn't want us to stop thinking, would he? Werner Schaefer has been associated with the ICS for many, many years, and I met him first at the meeting in Aachen in Germany. He's well known to you all. He used to be the membership secretary of the ICS and is now the scientific chairman, a co-chair of this meeting. So Werner, Professor Werner Schaefer, now at Pittsburgh University, please tell us about the urodynamic view of overactivity.
Thank you very much. The first time I ever met Norm Zinner was 40 years ago in Aachen at a real urodynamic event. He brought his beloved drop spectrometry in our outpatient clinic, and while we were standing around, including some German professors, and discussing very intelligent things, suddenly I heard a urinary stream, and there was Norm standing in the middle of the room, peeing in his spectrometer and said, "You see, it works." My chairman was not very impressed. Okay, so let's think about the urodynamic view of this term, overactive bladder. As you can see here, the lower tracing, the blue line or the green line, that's what we understand as Detrusor overactivity related to the definition as it is, usually accompanying the sensation of urgency. And I think what is a big mistake over the years, or has been and still is a big mistake over the years, is the fact that we should always include the urethral pressure. And if you look on the black line, which is the urethral pressure, I think the picture changes immediately. You see something is happening in the urethra before the detrusor contracts. And it seems to me, when we just look on the detrusor pressure line, there is a contraction, and that originated the idea of there is some overactivity. But when you take the urethral pressure into account, then it clearly means, I think, when the detrusor starts contracting after you're relaxing the sphincter, that's actually more a normal active behavior of the detrusor. And you can see here clearly by sphincter contraction also the detrusor is immediately inhibited again. So that means when we look on these kind of definitions, then you see that is too limited to talk about the sensation of overactive bladder and detrusor overactivity, but there are some other elements which are often ignored. So you see here, this is detrusor overactivity, you adding the information which is missing, that is the sphincter, and then we immediately see something changes, we have suddenly a normal active detrusor. Here's a different picture. You see the patient has urgency, and down there, the green line, the detrusor is not doing anything. So that would mean this is an overactive bladder with a completely passive detrusor. Well, the fact is the urethral pressure drops, and that may be the reason for the sensation, or maybe the fear of leakage which suddenly developed. When the sphincter relaxes, we don't know why the sphincter relaxes, it's involuntarily. And similarly here, this picture, you see this is urge incontinence, a strong detrusor contraction, and down there you see even leakage, but the observation is if you look systematically in the large group of patients, this urge incontinence only occurs when the sphincter relaxes. So it's not like many people seem to think that the detrusor contracts and that's leakage. No, the patient relaxes the sphincter. And that changes the story quite a bit. We know, here you see another example of detrusor overactivity, the green line, the strong detrusor contraction, and you see again this is going together with a drop in the black line, which is the urethral pressure. And that means when the patient has urgency, the detrusor contracts, but the sphincter also relaxes. And in this case, when the patient contracts the sphincter, then immediately the detrusor is inhibited. So that would be kind of a normal activity, and I don't see any reason to call that overactivity. But it can also happen, as you can see in this case, that the patient on the left side can control the sphincter very well, so the patient can interrupt the voiding, but when a strong involuntary detrusor contraction suddenly develops, then you can see that even the strongest sphincter contraction, which is a black line, going up to like 150 centimeters of water, cannot inhibit the detrusor. So this is a completely different situation. That may be a form of detrusor overactivity, or it may be a failure of the sphincter to inhibit the detrusor. So that's why we have in the ICS these different definitions of the phasic detrusor overactivity, which clearly shows that any kind of detrusor activity can be inhibited by the sphincter, or down there that the sphincter cannot inhibit the detrusor contraction. But you see at the very end, when the incontinence occurs, again, it occurs because the sphincter relaxes. So when we now look back to the original ICS definition and look to the part which hardly ever are referred to, then it says very clearly down there, involuntary detrusor contraction, don't use the term detrusor overactivity, but can be due to other forms of urethral vesicle dysfunction, that means an involuntary sphincter relaxation. Is this new information? No, actually it's not new information, and that's why it already had been included in the 2002 Standardization of Terminology, and there were many publications showing clear evidence that the urethra is involved. I just showed two examples here from Kulseng-Hansen and Kleffmark, saying very clearly the leakage mechanism in patients with urge incontinence proved to be a combination of urethral pressure decrease and detrusor pressure increase. Or here Sørensen, who clearly stated urethral pressure drop may be an essential factor in the so-called motor urge incontinence. And at that time was still optimistic and may in the future change the whole concept and treatment attitude to this disease. So it is not new. Here an example from treating a patient with urge incontinence with pelvic floor muscle training. You can see on the left side strong variations of urethral pressure, the black line, going together every time with the detrusor activity. That's called detrusor overactivity. I think this is just another example of normal activity. And on the right-hand side, you can see this patient changed by training when the sensation camp contracts the sphincter and the detrusor is not contracting anymore. That means by sphincter contraction, it suppresses what is called detrusor overactivity and keeps actually the lower urinary tract under control. So, what is the urodynamic evidence for overactive bladder detrusor overactivity? And I think actually the term overactive is rather pretentious and should be avoided. The sphincter is clearly involved in all these cases, and that, if anyhow described, is a form of underactivity, or actually what I think indicates a loss of central control. So let us restart with better, and that's definitely what Norm always asked for, with clear and only descriptive terminology, which does not pretend to know something which we really do not know. And that means we have to be clear. The symptom of urgency is an unpleasant sensation, but it's also an emotion. It's a fearful emotion, and that's what Alan pointed out, so it's a fear of leakage. And in urodynamics, we only should describe what we really find and not what we assume we see, and that is involuntary sphincter relaxation, involuntary detrusor contraction, and then it's very important to elaborate the timing, the dynamics, the patterns, the correlation between both. For example, can the sphincter inhibit the detrusor or not? And all these details are, I think, because of the current terminology, have been ignored for quite many years now. So that will be my wish for the 2012 updated terminology, to say urgency, sensation, and fearful emotion is suggestive of urodynamically demonstrable loss of lower urinary tract control, such as involuntary sphincter relaxation and or involuntary detrusor contraction, due to unclear forms of urethral vesicle or maybe brain dysfunction. So I think this is quite a change in our ideas, and I think we should not do things like, for example, this patient perception of intensity of urgency scale, because when you look on this, that means severe urgency actually is the ICS urgency, and all these others, less severe forms, actually is nothing but strong desire to void, or a first desire to void. And mild urgency then would be a non-compelling, little bit desire to, which is easy to defer. You know, this is a nonsense discussion. And it just leads to the idea that actually now everybody has some degree of urgency, so does everybody has OAB now? And when we look back, and Kari pointed out a little bit, there is a slide collection in the internet, which is very interesting, where a drug company takes credit for creating or making widely known the term creating a disease, OAB, and clearly understanding that this widening of the indication would change a niche product to a mass market opportunity. And recently I was at a meeting in Germany, and you see how this brainwash mechanism works. A leading German opinion leader made the statement about a man, his LUTs were clearly caused by OAB. So suddenly it is a disease. So we have to be very careful, and I think most important, we have to be clear in terminology, not pretentious, just describe what we see, and that's what Norm always asks for. Thank you.